The webinar is now live.
Thank you very much. Hello to everybody. My name is Andrew Wilson. Welcome to the public who may be watching, and welcome to the extraordinary governing body of Cheshire CCG. Thank you to colleagues for making time to attend this meeting. We have confirmed that we're quorate, so thank you for that. So apologies. Do we have apologies, please? We must have some apologies.
Yes, we have apologies from Dr. Leslie Appleton, Dr. Rachel Hall, Ian Ashworth, Chris Lynch, Dr. Matt Tyrer and Paula Wedd.
Lovely, thank you very much for that. Declarations of interest. Colleagues will, of course, all colleagues do have a public record of their interests on our website. This is an opportunity to highlight any items on that declaration which are particularly relevant to today's agenda, or to add any new items if anything new has occurred since you made that declaration. Nobody has raised a hand, so I'm taking that nobody has any difficulties with that. Thank you. So we move on to the next question, which is our public question in spot. This is a meeting held in public rather than a public meeting, but we do invite questions from members of the public submitted in advance. We are not aware of any questions that have been raised, so there is no items for that section, which takes us to section 3, which is our main business, and starting with the chairs and chief officers updates, or as we should call it, the chief officers and chairs updates, because I'm going to ask Claire to go first. So Claire, can I hand to you, please?
Thank you, Andrew. Good afternoon, everybody. Just a brief verbal update today.
Apologies, Claire. Sorry, I should have asked people to introduce themselves before they speak.
Sorry?
Could I just ask people to introduce themselves before they speak? I forgot to do that, sorry.
Apologies. Good afternoon, everybody. I'm Claire Watson. I'm the Accountable Officer of the CCG. So a quick verbal update today. I wanted to start with just say thank you to all of our staff. We had a fantastic staff event on last Friday. It was our Staff Champions Awards. And I think it was really important that we celebrate our staff and opportunity, particularly linking to our values: care, courage, compassion and challenge. So the award ceremony went off brilliantly. I think it was a really good opportunity to thank our staff for all the work that they've been doing over the past 18-24 months, recognising that we went into virtual working even before we became Cheshire CCG. And who knows whether we will be able to see all of our staff before the disestablishment of the CCG in March next year. But I think it was a really, really good event. So thank you to everyone who took part in that. Linked to that, I just wanted to sort of raise the issue of wellbeing and staff wellbeing. Obviously, we've got Chris here as our wellbeing champion from the governing body. Thank you, Chris, for the support that you give our staff. We are currently in the middle of our national staff survey. And we're also going to be introducing this week a Cheshire and Merseyside temperature check, which is a consistent approach across all of the CCGs in Cheshire and Merseyside to literally check in on our staff to see how they are at this unsettling time as we move through transition close down. I think it's important to recognise that. Last week we had the first We Are One webinar. So it was the first webinar to all the Cheshire and Merseyside CCGs and ICS staff. So the interim chief officer chaired that, and I was on the panel as the accountable officer, workforce and OD lead, and I chaired that group across Cheshire and Merseyside. I hope that staff across the CCG were assured that we are working as one in Cheshire and Merseyside and working on their behalf. So linked to that, there's an awful lot of work going on in terms of close down and transition of Cheshire CCG as part of Cheshire and Merseyside system. So I think I've said previously, we have a local group, and thank you to Peter and Pam who are involved in that. And also we are part of a great Cheshire and Merseyside, Cheshire and Merseyside close down and transition group. And that reports into the joint committee of the Cheshire and Merseyside CCGs to provide assurance that we're making progress in terms of due diligence in the safe transfer of staff and assets into Cheshire and Merseyside ICB. Alongside all the progress at Cheshire and Merseyside, which is considerable, and There are obviously a lot of work going on in our 2 places in terms of developing our governance, leadership, delivery of strategy and our ambition, and alongside that some of the sort of organisational development and the finance work. So thank you to colleagues who are involved in that work from the CCG and obviously partner organisations. Staff in the CCG are incredibly busy at the moment, as are all of our partners and obviously primary care in particular. So I want to say a massive thank you to everybody. We've got H2, second half of the year, financial planning. We're planning for winter and Neil will update on that. Obviously the ongoing quality and performance work. So the business as usual doesn't stop, and we want to continue that in terms of delivering our strategic objectives that we're incredibly proud of in terms of reducing inequality, obviously promoting climate change and all of the other work we're doing. So very, very busy time, but I think hugely rewarding. And I know that Cheshire CCG is really punching above its weight at the moment. We have an awful lot of staff working across Cheshire and Merseyside, leaning in, as the phrase goes, into the ICS and leading on a huge number of work streams that are really vital for our future as Cheshire and Merseyside. So thank you to everybody and for everyone's hard work, but very, very busy time. But I think we are doing everything we do, and this is what I remind colleagues all the time, both on the CCG webinar and as when we discuss it, exec team. What we're doing might seem quite processy and governance-y at the moment. Absolutely, this is to get the best outcome for our population of Cheshire into the new system of Cheshire and Merseyside from next April. So thank you. So that's it. Thank you, Andrew.
Thank you very much. Thank you for that. All I will add is that we do have another extraordinary governing body next Thursday, so that's something of an advance notice for the public, and that is to consider a paper about delegation to the joint committee, and that is part of the transition towards the ICB, which we expect to be in place for April this year. And that's the successor organisation to the CCG, so we are aligning functions and gaining a Cheshire and Merseyside view of CCG business as usual, so that there can be a safe handover between the CCGs to the Cheshire and Mersey level ICB for April, and that paper is for our consideration at an extraordinary governing body in a week's time. The other thing that probably is worth mentioning, colleagues will notice that there's an item withdrawn, 3.3 off our agenda here, and of course we are standing up our CCG place-based committees, one for Cheshire East and one for Cheshire West on the local authority footprint. The reason that item is drawn is partly that it's going to be heard on the agenda of the West Cheshire Place Committee, as it is about the West Cheshire Place rather than Cheshire East Place or the whole of Cheshire, and so those two committees are being stood up, and colleagues will be aware that we're inviting provider colleagues and local authority colleagues to sit on those committees with us, and that's a sort of a dress rehearsal for ways of working for the future. Then the other thing that probably we would mention, probably is worth mentioning, is we're here today to discuss the substantial item on the winter pressures. I think it's just to acknowledge that the pressure that the systems are under and that care systems are under, that's both healthcare and social care, for a variety of reasons, and to acknowledge that the service is not performing or being provided necessarily as people had previously expected it to because of those pressures and a number of difficulties, and that is something, you know, that is a very important context for our population. So I'll pause for any questions. No. So let's go then to our main item, which is 3.2, which is additional winter capacity commissioned service. So Neil, I think you're taking this paper for us.
Thanks, Andrew. If it's okay, I'll just give a brief overview of the paper before opening up to questions. I recognise that we have been through similar papers a number of times over the past year, so you're reasonably familiar with some of the background, but some of it is somewhat technical the way it's presented. So I'll just try and talk through the background and the headlines within the paper, if that's okay. So the paper is focusing particularly on something called the enhanced discharge funding, which is linked to the hospital discharge policy that was introduced during 2021. And that was a national programme which was aiming to reduce delayed discharges in hospitals. And you'll recall that part of that was about a significant investment in community-based services, which is how we have used this fund over the past year or so. As I touch on, there's quite a lot of numbers in here, and it's quite difficult at times, I recognise, to translate the numbers into reality in terms of what does it mean on the ground. So I look forward to some questions around that. Probably also helpful just to give some context that this was about reducing pressure on hospitals in terms of discharges, this funding. And as it stands today, we are looking at virtually full occupancy in all 3 of our local acute hospitals. And within that, I'm including significant numbers of escalation beds being opened. And a significant factor behind that is challenges that we continue to face around discharge, as well as increased need from our population following the pandemic. And we'll touch a little bit on some of the backgrounds to that. A couple of other things that are probably useful to know. At both East Cheshire Trust and Mid Cheshire in Cheshire East, we're currently running at the highest levels of long length of stay in Cheshire and Merseyside. So really challenged environment. And as of today, we had over 300 people in our 3 Cheshire hospitals who don't meet something called the criteria to reside, which effectively says they no longer have a need to be in the acute hospital. So I think you're getting the feel for the acute pressure that we're feeling in our hospitals, and we all recognise that that's a barometer of the wider health and care system pressures that we're seeing. And these plans that we're going to talk through today, which form part of the Cheshire Winter Plan, are a key part of our mitigations against that pressure. So the Hospital Discharge Fund is designed, as I say, to help people leaving hospital. There are clearly some national guidance that fits around this, making certain schemes eligible and certain not. One of the changes that you'll note referenced in the paper is during the first half of the year, the support that was available through this fund for members of the public moved from 6 weeks to 4 weeks, and that partially explains possibly counterintuitive numbers within there in terms of our levels of expenditure projected for winter versus the summer period. The other key things to mention are you can only spend this money on additional or new services or packages of care for members of the public. So you can't just switch funding that we've historically made for a person into this pot of money. It has to be something new. And the other key point is it is entirely about discharge. So we can't use this funding to do things like admission avoidance schemes. That has to be funded from separate pockets of money. Now, within the paper, the other things I guess to mention are there are things referenced in here that we aren't asking the governing body for approval on in terms of funding because they're being funded from other sources. And good examples are things like we are currently looking to expand the primary care hot hub capacity, but we're looking to do that using some of the national 250 million allocation that's been made to support access to general practice over winter. We've opened 17 beds in a mental health unit within a dementia care home within Cheshire to help people who are leaving mental health inpatient stays. And again, that's being funded via an allocation to Cheshire and Wirral Partnership. So where we've got alternative funding sources, we haven't included it in this paper. This is entirely about acute hospital discharge schemes. So the schemes we've got build on the ones that you'll be familiar with from Q1 and 2. There are some changes. We've seen some of the providers being stood down because we've found that either the quality of care we can get there or other related logistical matters mean that they weren't our preferred options for this time of year, or equally that the provider who we've been working with has pulled out of providing the service, often because of our single biggest challenge that we have, which is around workforce availability. So the the schemes that are included in the paper predominantly focus on bed-based care and trying to increase home-based care. And you'll be well aware from previous discussions within the CCG and also within the media that our biggest challenge, whilst workforce is clearly the overarching challenge, is particularly affecting the care sector, meaning that we've got some real difficulties discharging people home because we can't commission the levels of home-based care that we would like. And hence, within some of the schemes, we are looking at different ways of doing that, either through voluntary sector or through what we often call in-house care. So we're particularly looking at what is referred to in the paper as general nursing assistant services, which is our NHS community providers actually employing care staff who can support people in their own home, which in turn releases not just the acute bed-based pressures, but also the pressures in services like reablement services within the local authority or within some of our rapid response teams who are providing care to people in the absence of sufficient domiciliary care in the market. So just briefly focusing on the numbers, you can see the headline ask in the paper is a level of £9.4 million, and that compares to an expenditure in the first 6 months of the year of 9.8 million. And that goes back to the point I made earlier around the fact that the rules changed in Q1 from 6 weeks care to 4 weeks care. Yet at the same time, we are increasing the level of service we're looking to commission for winter in response to the likely predicted demand. The other point that is highlighted in the paper is when we've looked at our peers across Cheshire and Merseyside, Cheshire appears to be spending a higher proportion on this scheme than some of the other places. And if you work out our fair shares allocation, it's around £6 million compared to the 9.4 million. This said, we've had a number of conversations with NHS England as part of winter planning, and the general feedback is encouragement that we maximise use of this scheme to avoid people having unnecessary delays in hospital or in other bed-based services. The 9.4 million, just to flag, that is our, I think the correct accounting term is prudent estimate. So we believe that is the worst case scenario we're progressing, including that there. There's a number of schemes, or a small number of schemes within there, that we are increasingly believing we aren't going to be able to implement due to the workforce challenges that I've mentioned. I'd particularly draw attention to the 661,000 we have allocated as a costing to a standalone step-down unit to be staffed by the NHS. As I say, we've been working hard to develop a plan, but due to the workforce constraints we're seeing, we are increasingly believing that we won't progress that model, and we would look to develop additional domiciliary care in its place. So I can't say the whole 661,000 wouldn't be spent, but it wouldn't be spent on a further bed-based unit. And similarly, some of the other schemes, such as the GNA, the general nursing assistant models, are reliant on recruitment, and clearly until we recruit the staff, we wouldn't incur the expenditure. So we are, as I say, forecasting a worst case scenario here rather than a bullish estimate of what we're going to spend. So I'll stop talking at that point because I appreciate people may want to ask more detailed questions.
Do we have any questions from colleagues? Got no indications so far, Neil, but people may be. Yeah. So yeah, Linda and then Gwydion, please.
Hi there. So Neil, a couple of questions in terms of the expenditure, making sure that it is within the remit of the HDP, EDF, whatever you want to call it, and just to make sure that that has actually been looked at in a fairly robust way to make sure that we are compliant with the guidance around.
Yes, yes, indeed. And one of the things in the rules, which is probably most relevant to this, was the change from 6 to 4 weeks, and that is incredibly challenging because what happens at the end of the 4 weeks is that the responsible commissioner who hasn't fulfilled their duty becomes accountable. So, for example, if someone hasn't been assessed for CHC when they've been referred, then we would be responsible for the ongoing funding of that patient. Similarly, if the local authority hadn't completed a care assessment, they would be responsible. And it's a real challenge, and you can imagine some of the administrative processes that are required to make sure that happens. But yes, Linda, it is a key part of this, and I know your team are heavily involved in policing some of that in terms of the arrangements that go on in arranging payments here. And we recognise that this is open to audit, so it's quite important that, well, it's essential that we do ensure things comply with the national guidance on this.
And I suppose the other thing is just to say, in terms of the 4 weeks, we do have to be very careful as we get to the end of the period, towards the end of March, that we're not admitting people who don't have an exit strategy before the 31st of March, because obviously the funding finishes at this point and there is no sort of overlap for another 4 weeks after that, which there was for the first year of the scheme. So it's very important, I think, that we have really robust exit arrangements, and I'm sure you will have those in place. Yeah,
indeed, that is a real challenge, and almost as soon as we complete the planning for winter, we need to start planning for 22-23, because as described, the £9.4 million doesn't currently have any funding stream for next year, meaning we need to make some quite radical commissioning decisions as to how we're going to resolve that situation. Clearly not unique to Cheshire, it'll be a national challenge that everyone's grappling with, but a really difficult situation when we've built this infrastructure, assuming that the population need doesn't dissipate over the next 3 to 4 months, which is unlikely, I would guess.
Thank you, Neil. Can I bring in Gwydion and then Claire, please?
Thanks, Andy. Gwydion Rees, Governing Body GP. Thanks, Neil. So I think it's very difficult to pull together these plans at short notice, and I can see that there's a lot of work in it. I suppose just some thoughts, really. I think we're all aware, and hopefully the public listening are aware, that multiple services within the health and social care sector are saturated now. And I'm a little worried that we're still in the main going for downstream interventions. Now, I understand that you made it clear, well, this is all about hospital discharge, and I accept that. But I think we should be putting it in the public domain that, well, at least I think it's a mistake that you're spending 9 or so million very much in the acute sector. You're spending about 3 million in primary care, and you're essentially trying to manage a flood on the services by the downstream interventions. So I just want to think how that plays out into the next year, because I think that's quite important. I think we need to be thinking about our population's health. We need to be thinking about the quality of the care, including the access. So when we have things like hot hubs that are not evenly geographically spaced, some patients won't access them. So we're introducing a little bit of disadvantage there. And then we need to be very careful that we hold on to the value for money and the cost control. So I know you highlighted really clearly the challenge of what we could use this money for, but I just think that we should have it in the public domain that I at least think that this is a mistake in the way that we're trying to manage this pressure on the system. It's far more effective to keep people out of hospital. When I first started 15 years ago, we used to go around the wards at winter time because there aren't enough beds, and we used to procure extra beds in the community. This is a rehash of the same ideas, and I don't think it will do enough. But thank you. I can see that you're limited.
Yeah. It probably, this is the challenge, I guess, of bringing one dimension, and the fact that as every week we appear to have a different funding stream available to us. So there are things that are happening which I wouldn't say upstream, because they're probably near the dam. So there's quite a lot of investment currently being made available for things like ambulance services, and I don't mean ambulance services per se in terms of just conveying people to hospital. I mean in terms of things like 111, clinical assessment services, some of those pre-hospital opportunities. I guess the challenge with most of these things comes back to workforce, though, that we have to have suitable available workforce to enact those. But I wouldn't dispute the fact that we're dealing with the crisis here in our face, rather than the preventing the next stage. And without significant workforce, it's very difficult to get out of a vicious cycle on that one.
Thank you very much. Claire, I think you might have the last comment before we move on. We do have an AOB, which we're going to go to. It's okay with colleagues?
Oh, right, okay, thank you. So I think Neil's answered a lot of the questions I was going to, or some of the things I was going to say, or answer the questions. I think obviously we received the full winter plan last month. This is about the additional funding. My ask was just in terms of, I absolutely understand NHS England encouraging us to use as much as possible and almost above our fair share of the available funding. So what we don't want to do is lose that funding to Cheshire and Merseyside or Cheshire, but that will potentially increase the risk post end of the financial year, for all the reasons Linda and you've said, in terms of it's actually non-recurrent money, isn't it, that's going to stop. So the more we spend now, the more we get used to as a system. And we've had this conversation in A&E Delivery Board yesterday about layering and layering and layering services on top of each other, and actually in terms of evaluation, which ones have been successful and which ones haven't been successful. So it is just something to note, and I know we will manage that and sort of evaluate that through the two flow groups into the A&E Delivery Board. But I wanted the governing body and the public to be aware of that. I think in terms of just the primary care monies, again, workforce will be a pressure. And just to clarify, I know you didn't say this, Neil, but the 250 is national allocation for primary care winter monies. Our fair share is circa 3.2 million, which I think Gwydion mentioned as well. You know, in an ideal world, the offer wouldn't be a bed-based offer, but there are such pressures in Home First in terms of the social care and domiciliary care offer to the public, that we sometimes have to commission and fund services which aren't ideal but are better than keeping people in hospital. It's better to have them out of hospital in terms of that go home. So I think, you know, I would support this proposal and recommend it to the governing body. I would like to say thank you very much to Neil and the team for all the hard work that they've done on this. Obviously, it's not just CCG staff who've worked on it, it's all of our wider partners. But I think it's an enormous piece of work that I commend to the governing body. Thank you.
Thank you, Claire. A great way to end. So we don't have any further questions. So colleagues were asked, recommendations are on page 4 of your pack. There is quite a long recommendation and items to note, which I don't intend to read out. Colleagues will have read it. So I'll pause just to make sure everybody has had the opportunity to see those recommendations. And then I will look towards the governing body to approve this plan, which, as it says, will be an iterative plan to spend the budget as outlined. Are we in agreement to do that? Okay, I can see a lot of nodding heads, so thank you very much. So we'll take that as read. We do have an item, any other business, and it links back to my earlier comment about pressures in the system. And Christine is just going to give us a quick summary as the chair of our Quality, Safeguarding and Performance Committee of some of the issues in the system at the moment. And so if I can hand over to Christine, just really keep the governing body abreast of what is, of course, a very, very important item of our responsibility. Christine.
Thank you, Chair. Chris Morris, registered nurse. So the Quality, Safeguarding Performance Group met on 3rd of November, so last week, and we considered a usual detailed suite of papers across all of those areas. And this update is really just to escalate some of the points that we've heard mentioned so far. As previously reported for the Countess of Chester, the group awaits further assurances in relation to the quality risk profile that's been completed and this single item quality surveillance group that's being held with regulators to provide us with some information and further assurances around a number of quality metrics and pathway issues that had been identified some time ago. So I understand that meeting's taken place now, and I'm sure at the next meeting we'll get a full update on any mitigating actions that have been put in place as a result of that. And I think the group were really pleased to note that action was taking place. In addition, the group received a detailed paper on the implementation of the new patient administration system, Cerner, at the Countess of Chester, and thanks to all the staff and individuals who pulled together that work. The group noted that the risk on the CCG's register was proposed to have increased, and so we've asked for a further update on that at the next meeting, because clearly we need to understand the risk to our services if that is the case. So a further work is ongoing with that. As we've already heard from several speakers this afternoon, all the papers that we received presented a level of risk across the Cheshire system, and I think every time we turn our TVs on, we understand that this isn't just Cheshire that is facing very different circumstances in terms of provision of healthcare services. It's county and countrywide. We noted that the assurance processes that are in place, but they are different to previous times, given the challenges that our providers are facing. But we were assured that that the teams are doing everything that they possibly can to manage and mitigate the impact of risk to our residents and population. We noted, as Neil's already alluded to, that workforce shortages are a recurrent theme throughout all of the actions and mitigations that have been put in place, and we know that that's a much bigger problem to solve. What was really moving was the impact that we heard on patients and how real that actually is. So Cheshire and Merseyside Health Watch shared some valuable patient feedback with us that highlights the impact of the long waits, and I thought the group felt it was really important that we heard some of those words. I've just got two quotes that I'd like to share with you. And the first one is that my heart is getting worse and I can't get the care I need, which makes me afraid that I may die before I'm able to seek the care that I need. I was in hospital overnight earlier this week. And the second one is, I need access to hospital services ASAP to relieve pain and ensure no lasting damage is done to my eye. The waiting and the pain is really getting me down and my mental health is suffering. And I think, and the whole group felt that those are just two of a number of patient feedbacks that we heard, and we felt that actually we shouldn't lose sight of that in our everyday work and in our responsibilities as a governing body. Just to counter that, the group did hear that there is a task and finish group across Cheshire and Mersey to look at the impacts and delays on patients and population and their families, and clearly there's a key risk there is that it could further impact on health inequality. So we note that there's work going on, but actually hearing the voice of the patient is really important. So it was a long and helpful meeting. We have got some update papers which we will share with governing body members with any further detail or questions that they may have. But I think at the moment we want to give assurance to the governing body that we continue to push, challenge and seek the best assurances that we can during what is a difficult time.
Thank you, Chris. Are there any comments or questions for that? No, sorry, it was a sort of an unscheduled update, but it just felt that in the context of where we are, to have a governing body without mentioning these items and the governing body being appraised of it somehow felt wrong. So that's why we put it in as an AOB. So I think we'd all want to thank I think I said it was the committee, but it's now of course a group since we've had our place committees, that's looking into and doing a great job of looking into the quality, safeguarding and performance. But I think you said it, Chris, really, it's a very difficult time, and it's acknowledging that lots of work is going on, but things still aren't where anybody would quite want them to be if things were different. Okay, I don't think there are any comments, Chris. So thank you very much for that update. I think it was very helpful. Thank you, colleagues, for your contributions for the meeting. Don't despair. As I've already said, there is another governing body next week, so you won't be away from them for too long, and we'll see you there next week. So thank you very much for your attention and input today. Thank you.
Thank you.